This is Dr. Jeff Jarvis. I'm the medical director of the Williamson County EMS system, and we're going to talk about Pit Crew CPR. The things that I want to talk to you about here are the things that are going to be reinforced in the second half of this video. Those are the things that we have identified as being crucial to a good outcome in cardiac arrest. Obviously, our goal here is to do everything we can to optimize the conditions and the chances that our patients will have a good neurologic outcome. Things that this Pit Crew CPR approach are organized around is primarily choreography. Just like with NASCAR, where every single person involved in a pit crew has a specific role, they know what the role is and they know when to undertake that role. That's how we have to approach our cardiac arrest. It has to be a finely choreographed process if we want to optimize the metrics, the things that we know are important in increasing survival. The things that have been proven to improve outcome are early defibrillation and good, high quality, minimally interrupted CPR. So the things that were not on that list: intubation, mechanical CPR, drugs, IVs, hypothermia. None of that has been shown to improve survival. That doesn't mean it doesn't have a role. It's just not the crucial aspect of what does improve survival. And it turns out what improves survival in cardiac arrest is nothing sexy. It's not a device. It's the basics done exceedingly well over time, again and again and again. So we know it starts before we ever get the call with rapid recognition, bystander CPR, and early activation of the EMS system. When we do get involved, when we get there, the two things we need to focus on above all else is defibrillation and good, high quality, minimally interrupted CPR. So as soon as you walk up, get on the chest, begin good CPR. So we want that even as you're exposing the chest. Don't wait to begin compressions until the chest is exposed. Just start doing compressions, and then as you can, open the chest up and optimize your compressions. So part of optimizing compressions is using feedback. So we have feedback devices that tell you how well you're doing with your compressions. And the key to doing compressions is they need to be deep, they need to be fast, they need to be minimally interrupted. So what we do is make sure we press down 2 inches. We do so at a rate of between 100 and 120 a minute with a target of right at 110, but anywhere between 100 and 120 per minute is the rate that we're looking for. So we would consider that successful. Again, with each compression, come completely off of the chest. And when you press down and press up, make sure you do it directly perpendicular to the chest. There are some good studies that say if you're doing compressions at an angle, you're decreasing the effectiveness of those compressions. Now we know we're going to have to interrupt the compressions at some point to check the rhythm and to defibrillate and do other things. But when you do interrupt compressions, we don't want the interrupted flow to be any more than 7 seconds. Our Pit Crew CPR is organized around blocks of 2 minutes of CPR. The other thing we know about doing compressions, it is physically exhausting, and the longer you're doing compressions, the worse the quality of those compressions is. So we change out compressors, the people doing the compression, with every 2-minute cycle. As we are approaching the time where we're going to come off of the chest and check a rhythm, we know we want to go ahead and charge our monitor. And the reason we want to do that is as soon as we see VFib, we want to be able to shock and then get immediately back on the chest. We don't want to take that entire 7 seconds. So that's not the goal. The goal is much less than 7 seconds. And in order to do that, we can't be waiting for the monitor to charge. So we have to charge beforehand. Now, the thing that people may be concerned about is your hands are on the patient's chest, you're doing compressions, and you worry that there is a charged monitor there. I'd like to reassure you a little bit, because even if your hands, without gloves, were on the patient's chest, when we shock, you might feel it, you probably will feel it, but it's not going to be uncomfortable and it's not going to affect your heart. We have some decent literature on this. And as a matter of fact, if you wear 2 pairs of gloves, it's very difficult to detect the shock at all. Now, I'm not asking you to continue compressions when we defibrillate. I'm just trying to put your mind at ease that you can continue compressions while we're charging the device. You come off of the chest, we analyze, shock, and then go back on the chest. What do we do about ventilations? So for all patients, and this is going to be a little change from what we've done in the past, we are now minimizing our passive oxygenation. So we used to do passive oxygenation on all cardiac arrest of cardiac etiology in adults. And we would do that with a non-rebreather mask and an oropharyngeal airway. We would not do active ventilations. We are now going to restrict that to only patients who arrest in front of you from a presumed cardiac etiology. So let me spend a little bit of time on what cardiac etiology is, because I think it's been misunderstood. If you have a patient who has been running a fever, has been feeling fatigued, has been having a cough and shortness of breath for 3 days, then they go into arrest. That is not a cardiac etiology. That is a respiratory etiology. So that does not fit into cardiac. If you have a patient who's taken an overdose, that is not a cardiac event. If it's trauma, it's not a cardiac event. The only thing that is a cardiac event is a patient who is feeling good otherwise, has a sudden event where they may feel lightheaded, dizzy, they may have a seizure, they may have chest pain, and then they collapse. But it's a sudden event. That's cardiac etiology. We're looking for the sudden cardiac event. So if they do that in front of you as a witnessed arrest, then what I want us to do is ignore the airway until you get compressions established, get the defibrillator on. Then, when you have time, put an oropharyngeal in and a non-rebreather at a flush rate, which means turn it up as high as the regulator will go. Continue compressions at that point for 6 minutes. For all other arrest, I want you to establish ventilations early on as soon as you can without interrupting compressions, and that's the key. If there's just one of you, don't ventilate at all, just focus on your compressions. So when we bag, the things that I would like to tell you about bagging, make sure if you have the resources to do it that you're using a two-handed seal. Both hands, thumbs should be facing toward the chin, your fingers should be on the mandible, and it should lift the mandible up into the seal. Now that is going to feel very different than what most of us actually do. What most of us actually do is press down, and that's bad. Pressing down is bad because you're actually occluding the airway, and you're making it more difficult for air to go in the lungs and easier for us to oxygenate the cheeks, which isn't doing anyone any good, and insufflating the stomach, pushing air into the stomach. That is bad if you want to keep your uniform clean and if you want to keep the patient's airway without vomit. The more air that goes into the stomach, the more likely it is that they're going to vomit and ruin everyone's day. So let's not do that. When you squeeze the bag, squeeze gently, one time, for adults now, one time about every 6 seconds. You don't want to squeeze the entire bag. You don't need to put that much air into the patient's lungs, and as a matter of fact, that's actually detrimental. So the concept is, as you are doing positive pressure ventilation, if you have a large tidal volume, you're overexpanding the chest, and as you do that, you're increasing the interthoracic pressure, the pressure in the chest. When you do that, you're actually inhibiting blood flow coming back to the heart. So by putting a lot of tidal volume or squeezing the entire bag, you're actually hurting the patient because you're inhibiting blood return to the heart. We don't want to do that. So when you squeeze, squeeze gently with 3 fingers and your thumb. So I appreciate your attention and I appreciate your dedication to helping the citizens of Williamson County.